Good afternoon. My name is Jenna Maggard. I'm the president of the Idaho chapter of the Association for Professionals in Infection Control and Epidemiology, otherwise known as APIC. I would like to welcome you to the July webinar in our 2012 APIC HAI Prevention Learning Network series, offered in partnership with Qualis Health. We have planned this series to bring infection prevention information and expertise that addresses issues we face every day in our patient care world. If you have a subject that you'd like to see presented in the future, please take some time to pass along those ideas to us. Our emails are provided in the event flyers on the slide deck handout. My colleague, Jennifer Pelagi, APIC board member and Qualis Health consultant, will share some brief housekeeping comments and then introduce our dynamic guest speaker. Jennifer?
Thank you, Jenna. I'm Jennifer Pelagi, a quality improvement consultant with Qualis Health, which is the quality improvement organization for Idaho and Washington. I thank you all for joining us today. We have over 160 registrants and many additional listeners sharing those lines. And because of that reason, we will keep all of your lines muted during the main presentation. But we invite you to submit questions or comments in the chat section of your WebEx screen down in the lower right-hand corner. And you can do that throughout the presentation. We will also have a question and answer period at the end of the talk. I want to extend a special thank you to Acumentra Health, which is Oregon's QIO, and also to neighboring APIC chapters, state HAI coordinators, and hospital associations in helping us extend this invitation to healthcare providers across many settings in Idaho, Oregon, and Washington. RN continuing education credits are available for one contact hour as approved by the California Board of Registered Nursing. Those interested in receiving credit must complete the sign-in sheet that was emailed with your handouts, and be sure to include your email address and nursing license number. If you're not an RN but would like a participation certificate, please let us know on the sign-in sheet. The completed sign-in sheets can be emailed or faxed to me. A CEU certificate will then be emailed to you in about a month. Handouts were sent to registrants ahead of time and will also be made available on the Intermountain APIC website at apicintermountain.com. Also, you will be offered a brief online survey at the close of the presentation. It'll be a Survey Monkey, so please complete it. It's really short, and that way we can continue to improve our offerings and our format. Now let's focus on today's topic, summer epidemiology trends and healthcare impact. We are excited and honored to have with us today Jim Schwendiger, who is the director of the APIC program at the CDC and program director over many other things there. And I will let him do a little bit more of an introduction of what he does on a day-to-day basis as he goes into his presentation. So thank you, Jim. I'm turning it over to you.
Great. Thank you, Jennifer. And thank you, Jenna. Thank you all for inviting me to give this presentation. I hope it will meet the great ideas that you had and the goals of having this discussion. So as Jennifer mentioned, I'm at the Centers for Disease Control and Prevention in Atlanta, and my main job is that I manage the APIC program, which I have a slide about that a little further on. In a nutshell, APIC stands for the Epidemic Information Exchange System. And we're a secure system that allows CDC to talk with public health, primarily at the state level, but also with county and local health departments, as well as international partners such as Public Health Agency Canada and the Mexican Ministry of Health. We're secure so that we can carry information and exchange information about developing events and provisional events. And just for an example, we were heavily involved with events that I'm sure you all know about, going back to SARS and certainly H1N1 and a multitude of foodborne illnesses in between. And like I said, I'll speak a little bit more about APIC further on. So the first slide there, I tried to, be humorous and have a little bit of catch your attention, but I was asked to talk about seasonal infectious diseases and the impact that it might have on healthcare facilities. These are definitely both areas of interest to me. I'm a nurse practitioner by vocation. I've been a nurse for a long time. Not quite as long as Florence Nightingale, but quite, almost. So certainly I've been interested in healthcare-associated infections from many different angles. And one of the wonderful kind of additions of being involved with FTX is that we can quite early on find out and discuss developing events that do sometimes involve healthcare facilities. So my title there is a little tongue-in-cheek, picnics, camping, and vacations, oh my, but I hope to really make it relevant just to kind of pique your interest on the things that, you know, you may come in contact with or even things that you might be on the lookout for. Next slide. Again, this is our standard disclaimer. These are cleared content slides, but of course it's me as the presenter, and we have to have this slide. Next slide. So the objectives, we're going to review very quickly some examples of summer seasonal infectious disease situations, foodborne, vector-borne, travel-related, etc. We'll review some common disease situations associated with the summer season, which may impact healthcare facilities and staff, or even the community and you and your family. I'd like to just very briefly review some basic epidemiologic principles, which can be applied to clusters and outbreaks, small and large. Also, I'd like to maybe discuss the importance of immunizations and personal infection control during travel, just some ideas kind of going over the basics of things that I hope we're all aware of, and certainly never hurts to share with folks that may not be in the healthcare industry. And then last but not least, I'll cover some selected resources that you may be able to use as references for further information. Next slide. So CDC, if you're not familiar, which I hope you are, the Centers for Disease Control and Prevention, that is our mission statement there, the safer, healthier people. We really do try to be on the forefront of communicable and chemical and environmental disease processes. We have sections that are devoted to chronic diseases such as diabetes and hypertension. We have sections that are devoted to maternal child health and pediatric issues. We certainly have kind of a more famous and I think glamorous arm that deals with infectious diseases and is quite closely linked with our Epidemic Intelligence Service Training, the EIS program, which goes out and supports states and local public health departments with investigations of events. And, you know, we try to have our situational awareness, and that's a big part of what MPX does, to really see what we can do to try to as early as possible, identify situations where we may be of assistance to state and local public health. So the actions there, I won't read the slide to you. Certainly prevention is a big, the primary kind of mission, but prevention certainly requires awareness and preparation and surveillance and a bunch of other supporting activities. Health education is another big one. I mentioned early identification and intervention, and certainly research. I don't want to give my research colleagues any less credit than they deserve. There's a lot of research activities into everything from immunizations to antibiotic utilization and treatment to laboratory diagnostic testing. So research is really at the heart of the CDC mission as well. Next slide. So what do we have during the summer? And again, this was difficult. I told Jennifer early on, it was difficult to really kind of keep this narrowed. Every time I started to draft notes, I would end up, going very wide, but I really tried to bring it back in. So some of these certainly occurred to you, and would come to your mind if you were asked to, mention, okay, tell me a summertime kind of illness situation. Certainly the upper respiratory infections, echovirus, Coxsackie, parainfluenza, rhinovirus, summer colds, even influenza. Summer influenza does occur. And it occurs quite commonly. It's not at the levels of what we consider the typical season and flu season, but it certainly occurs. Gastrointestinal illnesses, enterovirus, norovirus, which I'll talk about in a little bit, the cruise line issues or summer camp kind of viral gastroenteritis. There's certainly staph and botulism. Thankfully not as much as there could be, but they certainly need to be thought of or considered when there's a cluster of any kind of GI disease that's associated with a common activity such as a picnic or everyone went to this potluck. Vector-borne diseases, of course, I mean, we think about mosquitoes. You folks out west, more than we in the southeast, have to worry about ticks. And, you know, we're discovering new tick-borne illnesses kind of, maybe not every day, but certainly recently there's been a couple more discovered. So Lyme disease, Rocky Mountain spotted fever, ehrlichiosis, you know, we really have to think about those. And in the other category, I threw a couple of odd ones. I mean, amoebas, certainly, Naegleria being kind of the most common. You know, there's been a couple of events in the past 6 months that have been pretty high profile in the media. Unfortunately, it's typically young people because there is a conduit between the sinuses and the cranial vault. You know, the typical mechanism is swimming or water skiing. High velocity water from fresh water gets up past really the threshold where it normally would in the sinuses. And if there's amoebas, they take advantage. I mean, they're opportunistic pathogens. And, you know, the very sad thing about CAM infections is they're typically fatal. So there's a lot of research going into environmental surveys and really looking at, is there a way to maybe more early on identify a CAM infection in order to intervene and provide anti-amoebic medications to try to prevent death or serious disability. Certainly tetanus is an issue. I mean, it's an issue year-round when we think about wounds and other traditional kind of situations. But, you know, tetanus, because of outdoor activities and because of environmental kind of activities, rock climbing, hiking, canoeing, white river rafting, you know, any abrasions or kind of injuries to the skin and mucous membrane certainly, you know, would bring the risk of tetanus up at least to the awareness level. And certainly MRSA, I mean, methicillin-resistant Staph aureus, it's kind of, you know, that's really more of a health-associated issue. However, as we all know, it's really become a community issue as well. There's been a lot of really good research, some of which had CDC involvement, to look at really what is the community distribution and colonization of MRSA. And I believe that the first studies were quite surprising. You know, so now we even have different categories, and certainly the healthcare infection control folks know this more than I, but, you know, we have kind of different categories. We you know, split between, you know, it's a community-acquired MRSA infection or it's a iatrogenic or hospital-acquired MRSA. So it's certainly something we need to be aware of whenever there's illness that makes us suspicious. So why do these things occur during the summer? Well, I mean, and this is in no particular precedence of my list, and it's not an exhaustive list, but, you know, the number one, you think about, you know, school-age kids mix. Well, where do they mix? Well, summer activities, you know, swim clubs, camps, whether they're formal stay-away camps or day camps, you know, even if it's just a pickup basketball league. I mean, it's kids that come from various settings where they may not mix during the year, but during the summer they do. So anytime you have kids, or certainly adults, I mean, we all know this from conferences, you know, you have adults from various geographic areas come together, there's always the risk of everyone bringing kind of their regional illnesses, their regional bugs, if you will, into the common population area. So camps I mentioned, again, it's really the, you know, the camps. Not only you have to think about the foodborne illnesses, certainly because the kids are eating what is being served to them, as well as I mentioned earlier, the fact that there's, you know, kids and staff coming from geographic areas that are naive to that individual. Vacations and travel, of course. I mean, I think the classic, certainly for epi and public health surveillance training, is to think about a cruise line. You know, people come from all over the country, certainly sometimes from different countries, and all of a sudden are, all shoved into this big tin can that's floating on the water and, are in close proximity and associated and, touching the doorknobs and swimming together and all this kind of mixing. Even with the best infection control and infection control awareness, there's going to be the chance of acquiring whatever the other person brings into that situation. Seasonal activities such as grilling. Again, this is kind of a reach, I think, but there's actually, I was looking at our foodborne outbreak websites, which I'll mention in a few slides in preparing this, and there really is a push for food preparation awareness in the summer once the weather starts getting nice. Reminding folks, hey, you really need to thoroughly cook meat. You need to thoroughly cook poultry. You really need to thoroughly cook fish. And, not only for the bacterial possibilities, but also for certain parasites. And, depending on is it fresh game, is it something that's been frozen. So definitely, grilling and picnicking, I should have put on there as well, are certainly things to be aware of. And last but not least, certainly the recreational activities we spoke of a few minutes ago. Folks are out being active, and that's great. Out in the fresh air, out in the mountains hiking, out fishing, out kayaking. It's just when you get out of where you are every day, you are potentially exposed to that much more. Next slide. So, knowing that you all are focused on healthcare facilities, I want to kind of bring it back with just two very quick case examples. They are absolutely taken from real life. None of this is made up, and again, I think they're fairly representative, and you all likely have your own anecdotes. The first one is that we had a staff physician that I work with went on a cruise, and I won't mention the theme park company that ran the cruise, but you can guess from that. They basically were infected with norovirus on this cruise line. He came back his first day, and I think they went to Dunkin' Donuts, although, again, the donuts weren't the source, they were just the vector, into a staff meeting, and basically, out of the 35 attendees that admitted to taking a donut, 31 of them became ill. And actually, of those 31, 26 had laboratory diagnostic confirmation that it was the same norovirus strain. And, this is a physician. This is somebody who's astute, who knows, and, it just really, I think, brings to light that it can happen to any of us. And, how do we combat this? Well, we, make sure that we're aware, and we make sure that we practice, good hand washing, and we practice good personal infection control. The next case example, so actually this is not someone I worked directly with, but I know of this case. Basically a pharmacist and their family went to Europe, and one of the children had not been successfully immunized or vaccinated for measles. And as you likely know, Europe has some lower rates for vaccination and immunization rates for a lot of childhood diseases. So basically the child acquired measles. And the pharmacist, it turned out, did not, for whatever reason, have clinical immunity. So they came back, returned to work, and basically had an adult case of measles. And were pretty unpleasant and miserable. And this, at least 10 days, it was probably a little more than 10, that they really just were too sick and felt too ill to work. So, just off the top of the head, two quick examples of things that you might not think about, but certainly are out there to be aware of. Next slide. So, I wanted to do a polling question if we could, just to see. I mean, it's great, and thank you all for dialing in and taking the hour to dial in, but I'm curious, how many of you have investigated seasonal, I guess that should be seasonal or recreational illnesses in your facility that spread or had potential to spread to staff, patients, or visitors? And I believe, do you want to, there it is. So on the right side or right bottom of my screen, is just a quick yes, no. And I'm just kind of curious. This doesn't count for anything, and I don't know who voted yes or no. Or I'm just kind of curious what y'all might have as far as experience. So please go ahead and answer that if you don't mind. Okay, well, while we're waiting for that to pop up, maybe next slide? If we can. Yeah. So healthcare facilities, again, knowing that most of the listeners are associated with some type of clinical facility, one of the things that I really do like to listen to with our hospital infection control program, our hospital-acquired illness program, is really, we think about, okay, the staff, and we really do have a push to make sure that staff are vaccinated, save for seasonal influenza. Certainly staff are vaccinated for hepatitis B, hepatitis A in a lot of programs is offered at no cost. But, I wonder if a lot of times we think beyond just kind of where our immediate connection is. We might be focused more on the staff, or we might be focused more on the patients. And I know from my staff nursing days, I really wasn't aware of or didn't think a lot about visitors and the role that they play certainly as, and I hate to use the term, but, disease vectors, but certainly potential for transmitting various illness-causing agents, not only from outside in the community, but even from part of the facility to another part. So, we need to be aware of that. Visitors from out of town, I have a bullet there. Again, there's a couple of anecdotes I could have put on this slide that there were small clusters of illness that were traced to individuals that had flown in and traveled in for, a fairly dramatic kind of illness. Actually, the one that's coming to mind is a family came from various parts of the country because the grandmother had needed a bypass, a cardiac bypass. And there was a cluster of illness that basically was traced back to one of the visitors from out of town. So, what should we look at? And when should we start thinking that this may be something connected to the cluster we're looking at, or even the, before it's identified as a cluster, the case that we're looking at? Well, so, unusual or non-immediately anticipated pathogens. And again, because of the outdoor and summertime focus, I say due to outdoor activity, but of course that could be due to, travel from out of town, due to a hospitalization, due to outdoor activity. So the bacterial ones, and again, this is not an exhaustive list, just some examples to think about. So bacterial, Clostridium, of course, botulism for both food as well as wound. Campylobacter, certainly Shigella, Listeria. If you've been following certainly the infection control media, there's just now a Listeria outbreak associated with unpasteurized milk products that's just kind of winding down, so to speak. Viral, certainly we mentioned norovirus. Measles, mumps, rubella. I mean, it still happens. There, every year, it seems like in the last few years, there's been at least a fairly large cluster in the Midwest. Measles or certainly mumps. Rhinovirus, of course. I mean, the upper respiratory viruses are there, and, they're ubiquitous. The ones we may not think of, they're a little more exotic and a little less common. Some of the fungal diseases. I mean, coccidioidomycosis, valley fever. Certainly there were a couple of media stories in the last couple of weeks about increased incidence in Southern California. Again, that's kind of the place you think classically about coccidioidomycosis, but it's ubiquitous. I actually didn't know this until I looked into this. It's actually been cultivated from soil in all 50 states. I would assume that because of the weather patterns in Alaska, that it has a much shorter kind of risk period, but certainly it's there. I mean, it's ubiquitous. And, certainly anyone, the classic rose gardener with, sporotrichosis with an injury and an infection. And then the others that are definitely more exotic, but certainly do occur and, need to be caught. The amoebas we talked about with TAM is the classic presentation, staph toxins, and many others. So before we go to the next slide, so I got the answers to the polling, and actually 54% of respondents said that they have been involved. So that's very good. 27% said no, and 18% had no answer. So I'm glad, and I hope, like I said, I meet the objectives that we set out to meet with this talk. Next slide. So some basics, epi and surveillance, and I really do apologize in advance. I don't mean to talk down to anyone. I'm a nurse epidemiologist, but I sit a lot of times and am wowed by the things I don't know. I think the more I know, the more I realize I don't know. So please, this is just a quick off-the-cuff kind of, Epi 101, I guess, for all of us, really, for all of us in a healthcare facility, all of us in any kind of community care setting, really all of us as healthcare professionals. So number one, be aware of seasonal trends and expected typical rates. So as we started, flu season. Well, we call it flu season for a reason. Does that mean you should kind of be really concerned if there's a case of influenza in August? Well, no, but I think it should kind of pique your interest. And certainly if there's a cluster or, you see 5 or 6 or 8, or you see a family or a group of neighbors that come in or that you hear about that have influenza-like illness, well, that should get you thinking. A flu case in January, well, we're in the middle of it. So I would not be as kind of surprised or even as curious than if it were, say, July. And that's just one of the quick examples. I mean, certainly there's any number of conditions that would mean that, look, it happens in this season or it doesn't happen typically. Likewise, be aware of aberrations, so novel or unusual pathogens. We mentioned coccidioidomycosis. It's a ubiquitous agent, but thankfully it typically doesn't cause symptomatic disease. That being said, there's a bunch of exceptions to that. Folks with pulmonary disease, underlying lung disease, even if it's asthma, certainly are a little more at risk than folks with what's considered normal pulmonary function. But really, anything that kind of strikes you as unusual or interesting or novel should really pique your interest as well. Larger than normal case numbers, I kind of use the off-the-cuff example of influenza. If you have 10 cases in a school, in January, well, that's probably low, depending on, cyclical rates of infection. If you have, 100 cases, well, then you really need to look at the historic reporting. And, I do speak a little further about one of the resources. I don't think I mentioned it by name, and if I don't, I apologize. But during flu season, certainly FluNet, which, www.cdc.gov/FluNet is a great resource for normal or expected infection rates wherever. And the geographic data can be parsed a number of different ways, by state, by county, by location, by zip code, I believe. So, if you're not familiar, if that's something that you come in contact with or, want to start being more aware of, it would be good to see what resources are out there as far as letting you know what the standard kind of expected rates for different illnesses are. And that's really one of the things that I believe CDC, in conjunction with all our partners, can provide to you. So the next big bullet, this is a big one, know who to contact for reporting or more information. A lot of folks have, everyone has an infection control group in their facility. Sometimes it's, if it's a big medical center, it's a bunch of people. If it's a small facility, it might be someone who's wearing 6 other hats. But there really is someone, and a lot of you guys are that someone, that is responsible for infection control and for EPI and for all those activities that are just, thankless, sadly, but very, very important. So know who to ask if you don't know. Is that your county? And in some states, yes. I mean, as we all know, the states are kind of different. There's very centralized states. There's very decentralized states. So I wish I knew I could say, oh, yeah, call this person, then this person, then this person. I wouldn't try because I would mess it up and I'd be wrong. But, know who to contact. Local state health departments, certainly, I don't think, they mind ever getting a call, especially if it ends up, bringing something to everyone's attention earlier than it might otherwise be brought to their attention. And, I don't mean to make this the last but not least, but CDC. I mean, we have an 800 toll-free 24-hour number, 1-800-CDC-INFO, that, they are a contract company that basically, wow, to talk about a thankless task, they have basically worked with every program at CDC to try to compile resources really aimed at the public, but there is an arm that is specific for healthcare as an industry to be able to have resources and information. Some of that takes the form of printed materials. Some of it is our web links. Some of it is, canned text that they can send you in an email. But certainly it's a good place to start. And last but not least, and this is last but not least, and I have a disclaimer here that I don't want to encourage anyone to totally jump over their reporting chain. But if it's something that really, really concerns you enough and you can't get a hold of anyone for some reason, we have a 24/7, 365 facility here in Atlanta, the CDC Emergency Operations Center. That's the phone number, 770-488-7100. Please don't call them and say Jim told me to call you, because they will yell at me. But honestly, in all seriousness, we have clinicians call. I mean, that is actually the way that public health tells individual clinicians to call after hours to get a hold of botulism toxin, because we have one of the central supplies, and we have a regional distribution of that. Certainly, if nothing else, they can direct people to the local resource. But if it's something that's that aberrant or that dramatic, it really should come to our attention. And, again, we certainly share information with all the jurisdictions. We don't do that kind of movie cliche of we're the federal government and we're here to help kind of thing. We only come in and assist as a question, but we certainly share information, and, very, very well established that we work with state health departments and local and county health departments. Next slide. So just one more, this is the last one, I promise. Just one more question. How many of you are familiar with the reporting procedures for unusual conditions or those conditions on your state notifiable conditions list? And hopefully, if you don't know what your state notifiable conditions list is, I really encourage you to find it. And it should be on your state health department website. There is a nationally notifiable disease conditions list, which is on the CDC website. And I believe most of the states, I don't know them all intimately, but most of the states echo that and then maybe add, say if it's a large agricultural state, they may add some veterinary or other zoonotic conditions versus, say, a state that's not very agrarian. So I wondered if you don't mind holding in and answering on that, if you're familiar with procedures for reporting, right? And while we wait for that, so again, when we get to the resources, I list off a whole bunch, and again, it's not exhaustive, and I try not to overwhelm everyone, but, everyone's local public health department, I think, is a good place to start if you're not familiar with their websites. Certainly the state Department of Public Health and definitely CDC. So we'll move on to the next slide. So some of the things to be thinking about if you do notice something unusual, you do notice something that, kind of has you thinking, one of those moments, like the song said, things that make you go, Data collection and reporting, what really helps, who is it? It's a bunch of kids. It's a bunch of elderly. It's a group of folks that you really can't pin down to any descriptor or one descriptor, but certainly basic demographics. Age, medical status if applicable, and by that I refer to, it actually was only a few months ago we had a very large outbreak of a particular illness that was associated with dialysis centers in a couple of different states. So that, certainly makes the EPI investigator's job a little easier and certainly a little quicker. If there's some kind of commonality in the affected group, then most of the time we can then narrow down the investigatory process so that we arrive at an answer quicker. Immunization status definitely is part of it. And, for example of that, if, as the anecdote I gave earlier, that you find out that this family, well, for whatever reason, whether they opted out of vaccination or for some reason they have a genetic condition that doesn't allow them to develop and mount an immunity, that can sometimes narrow down the investigatory time as well. Diagnoses if known. And again, that could be something as broad as gastrointestinal illness, gastroenteritis, whether it's been worked up and confirmed with diagnostic testing. Well, we know it's, a diarrheal illness, but it's not E. coli or it's not salmonella. Certainly, any of that data helps to narrow down and quicken the chance of getting an ultimate diagnostic answer, and then helping to look at, simultaneously, most of the time, look at how is it being spread and what can we do to mitigate things. Descriptions of signs, symptoms, onset, progression. A rash that developed a day after fever onset could be and likely is different from a rash that develops before fever onset. Again, everyone's biochemistry is different, and certainly, certain age groups have different disease manifestations to a degree, but all of that data really helps. And last but not least, of course, geographic info, cluster mapping. And just two examples. So, a micro-location, the EPIs love to use that term, micro and macro location. So micro-location, like a family unit. Hey, it was this neighborhood had a neighborhood potluck, or, this family, really this household, or a common activity. Hey, everybody went to this church picnic. Everyone went to this water park, et cetera. A lot of times that often is the starting point to see, okay, well, if everyone went to this water park and then everyone all of a sudden developed a febrile diarrheal illness, well, we're going to start thinking a certain way and start investigating. So before we go on to the next slide, so the answers, 78% of you answered yes, which is awesome, and 7 answered no, and there was no answer out of 15. So that's great. And I'm very glad to see that. I think it's one of those, you think, well, okay, I know where to start. So that's very good, and I'm glad to see that. Next slide. So immunizations, and I'm shifting gears a little bit, I apologize, and I know that there's folks that, for whatever reason, may not be strong advocates of immunization. I'm not here to debate that. I actually really think that there's data for almost every argument. Certainly the first test is do no harm. So if it's a person that for some clinical reason has a contraindication to vaccination or immunization, great. That's certainly valid. But I think that, as we all know from our basic training, whether it's nursing or laboratory or medicine or wherever, or EPI, there is really something for herd immunity. There's the reason why polio is almost eradicated worldwide, because we all were vaccinated. We all were immunized, actually. as kids. And, you know, you do that and the pool of natural cases drops and drops and drops until it's eliminated. Smallpox has been eradicated. You know, any number of other, you know, typical diseases that 100 years ago were ubiquitous are gone or are very rare. So what should you be immunized against? Again, this is slanted a little more towards the healthcare provider kind of population, but there's two links there, you know, if there's ever any questions. So the first one looks at, has a couple of really nice printable references in multiple sources for vaccine schedules. You know, hey, what is your kid going to get at their 8-year visit or their 8-month visit, or, you know, what, now there's new recommendations for shingles virus for adults to, you know, be re-immunized, kind of a booster, so to speak, even if you had documented chickenpox as a child. So, I mean, I think it's always good to keep up on that, not only for your own health and safety, but also for your family and if your role dictates for your patients. The second link there, I really encourage, if you're going to travel anywhere out of the country, you know, look at our travel pages. We have everything from vaccinations, recommended vaccinations, to, you know, current clinical issues or concerns, to safety concerns. Actually, we link to Department of State, and if there's travel restrictions based on safety, not clinical safety, but physical safety, we link to those as well. It's a really good start and a really good resource if you're not aware of, to look through and just kind of browse through the travel pages on the CDC website. Why immunize? Again, I'm not trying to debate anyone or push any buttons, but, you know, this is a classic study, you know, looking at pertussis. And thankfully, I mean, you know, kids get really sick with pertussis and it's sometimes fatal. Adults, thankfully, don't, but you have this miserable cough for months. You know, so the statistics here speak for themselves. You know, 1974, about 80% of children were vaccinated in Japan. They had 393 cases. 76, by 76, 2 years later, the vaccination rate had dipped, you know, actually dropped precipitously, I would say, from 80 to 10%. 2 years after that, there were 13,000 documented confirmed clinical cases with 41 deaths. I mean, those numbers just, you know, cannot be argued against. You know, there were a number of reasons in this study that I quote from in MMWR, the Morbidity and Mortality Weekly Report, you know, does cite reasons why the vaccination rate dropped, but a large part of that was public opinion. There were some shortages. There was one shortage in 1975, I believe. There was a change in kind of the recommendations. So there's various reasons, but the largest by far was public awareness and public opinion. And, you know, that's pretty dramatic in 2 years to go from an 80% vaccination rate to 10%. And, again, the results of that are absolute black and white. If you ever need to or wish to discuss with someone, you know, about the benefits, not only to the individual but also to the community, this NIH resource is wonderful. And the document itself is the benefits of vaccinating. It's a great publication. So other protective steps. Certainly vaccination is a big one. You know, if you're traveling to a yellow fever endemic area and you're going to be out in the middle of nowhere and you're going to be bitten by mosquitoes, you know, certainly thinking about a yellow fever vaccine is probably prudent. But what are the other things? Hand washing. And again, I really don't want to be beating a dead horse, but, you know, hand washing. We know absolutely from study after study after study, and a lot of the really good data that came out of the H1N1 epidemic was that there's a huge positive impact of hand washing. And, you know, it really cuts transmission rates. It really cuts disease acquisition. It really, really works. You know, and, okay, so you're not near any sink or any running water, or it's questionable. Well, there's hand wipes. I mean, now there's, however many different brands of hand wipes that has an agent in it, or at least one agent that can kill viral particles, that can kill most bacteria. Certainly there's waterless cleaner, hand sanitizer. I don't know if there's any excuse for any of us to not have some resource with us wherever we go, in our briefcase, in our purse, in our backpack, to be able to, deal with, hey, I was just, shaking somebody's hand and I saw them sneeze into it kind of thing. Cough hygiene, certainly. I mean, to cover your cough, there's a lot of really good data out of the H1N1 influenza pandemic that looked again at cough hygiene and teaching kids cover your cough, and teaching not just kids, teaching adults, cover your cough, cover your sneeze. I put face masks there because there may be situations where, and this is beyond the typical, certainly infection control protocols that we have in our facilities that say, okay, if someone's in respiratory isolation, you will wear a respirator, you will wear an N95. This is, looking at the data, and there's less from the United States than there is from the international community about, face masks being voluntarily worn by people. And again, what I really try to make clear to my patients is that the folks that wear, say, a surgical mask, or what passes for the community, kind of surgical mask, protects everyone else more than it does them. But you know what? That's something to be commended. If you're ill and you have an upper respiratory infection, you know what? I give you a pat on the back for, putting on a face mask if you go on a crowded subway or, into a crowded building or something. And I think that hopefully the attached kind of stigmatism and other potential, I think definitely was mitigated during the H1N1 pandemic. But certainly I think it would really be a nice societal pat on the back or encouragement for folks to think about that. And really, you're doing a public service. Water and food awareness, absolutely, for travel. Bottled water. And we hear stories, and certainly there's some clinical confirmation of some countries, certainly it's bottled water, but it's water in a bottle. It's, water out of their tap or out of this well that they put into a bottle. Sometimes for nefarious reasons, certainly sometimes not. But, make sure that if you're in an area of concern, that you break the seal. And if it looks like it's refilled, assume it is and say, sorry, thanks, but no thanks. Again, you have to temper that. I mean, if you're dehydrated clinically, and it's one of those tough choices. But typically, unless you're out in the middle of nowhere, there's going to be a resource where you can actually get safely confirmed fresh water that came from the manufacturer in a sealed bottle. Common travel advice, and I don't mean to make this all about travel, but avoid ice and iced foods, ice and drinks. The water may be fine, but I think there's a misconception that if water is frozen, it kills everything. Well, that's not true. There's many, many examples of outbreaks of, say, E. coli or whatever from ice. And the water was fine. It was just the ice that the beverage is made with, or even the ice that the food was stored in was not. Fresh vegetables and fruits should be washed. Again, well, what if you wash them in contaminated water? Well, hopefully we're not faced with that choice. If all else fails, cook it. And, if you heat and boil the water, it's going to be treated. Of course, then it's not fresh fruit and vegetables. Seafood and other fresh animal products, again, it's be aware. And I always kind of, when I give a talk that touches on any of this, I always want to caution people, I'm not trying to take anybody's fun away, and certainly don't want to make you paranoid or any of that, but it's really being aware. Fresh seafood, eating fresh seafood when I was deployed to Haiti, I think would have been kind of reckless. No insult to the country of Haiti. You know, when I was there right after the earthquake, the infrastructures just weren't there. You know, would I eat fresh seafood now? Probably, I guess depending on the particular circumstance. But I would certainly be more prone to now than I was that February after the earthquake. And that's just one example. Certainly fresh meat, make sure it's cooked appropriately. You know, make sure if you can that you know the source. You know, common sense. If it seems questionable, it's probably not good to do. Social distancing, again, the H1N1 data really showed us that folks that voluntarily sequestered themselves, you know, you're really protecting everyone else. Or if you know that, you know, so-and-so in the office has been hacking and sneezing and probably looks like they have the flu, well, I don't think that they'll be insulted if you keep your distance. You know, social distancing definitely has a role to play, not just in influenza, but in any upper respiratory illness, as well as, you know, certain foodborne illnesses or contact kind of fomite kind of illnesses like norovirus. You don't want to shake hands with the person if they didn't wash their hands, or if you don't know they washed their hands after they just went to the restroom. Last but not least on this slide, have a travel kit. You know, again, depending on where you're going. If you're going to the boonies of Nigeria, well, I think I'd talk to a travel specialist, you know, travel medicine specialist, or look on the CDC website for Kenya. That would be different from you were going to Nairobi for 2 days and you were going to leave the hotel because you're going to a conference. I think we all understand that. But certainly it's not, you know, beyond the realm of possibility that you might want to take antibiotics for prophylaxis, such as malaria, or for self-care. I mean, a lot of folks, and I'm not trying to make this controversial for the overuse of antibiotic people, but, you know, I think depending on where you're going, it's not a bad idea to have some antibiotics with you. So some specific resources, I won't read these to you. I really do encourage, if you're not familiar with them, the Pink Book really talks about vaccine-preventable diseases. It has tons of data and resources for talking about vaccinations, preventing healthcare-associated infections. That's a great document that certainly some of you may have had a hand in writing or editing. It's a great resource to know about. Next slide. So, again, I've already covered some of these. I will definitely mention, and I know I'm kind of running over time here, but I'll mention some of the specific resources. So certainly the website, I've listed, you know, different sections, the food safety page, the traveler's health page, CDC Health Alert Network messages. If you don't get on messages, please, it's free. You know, they're sent out on various topics. You know, certain recalls that rise to a certain level, certain conditions. Basically, the website there's an archive that you can look and see what really the topics are. COCA updates, one of the sister teams of my team, the Clinician Communication Team. COCA stands for the Clinician Outreach Communication Activity, and they basically put out information primarily aimed at clinicians. And clinician here is a little broader than you may think. It's not just physicians, nurses, and healthcare providers, but first responders certainly. Anyone really associated with healthcare or any kind of community care, I think, could find things of interest. And then the last bullet there, you can do RSS feeds from any, and I believe all of our pages. Next slide. Again, more specific kind of resources. Division of Healthcare Quality Promotion, which is actually DHQP. I apologize for that typo. DGMQ is Division of Global Migration and Quarantine. I don't know why I did that. Division of Healthcare Quality Promotion has the oversight for healthcare-associated infections. The TB activity, FoodNet, and certainly partner websites, the FDA, USDA. For general preparedness, I would be remiss not to mention ready.gov. You know, they really are a clearinghouse for information from both CDC as well as other federal partners to look at preparedness for a natural disaster, preparedness for a pandemic, preparedness for a house fire. I mean, we really all need to be aware of kind of the common potential incidents and try to protect ourselves and our families. Next slide. So just really quick, I was just kind of highlighting that on the Traveler's Health site, just as an example, it gives an update about the hand, foot, and mouth disease in Vietnam and Cambodia. Next slide. This is one that, again, is seasonally specific, because kids are out at petting zoos and out at the zoo and out at, community kind of festivals, make sure they're aware and you're aware, hey, there's a petting zoo. Well, and thankfully now at the zoo that I've been to, there are hand washing stations and there are hand sanitizer stations. Next slide. So a couple of programs that I know I'm veering towards my time, but I did want to mention just three, including my own. You may not know about these because we're not really kind of crowing at the top of the building to make folks aware. But I mainly want you all to know that there's a network of resources and systems out there that are exchanging information to help you guys not only report from the reporting side, so your information will go in on the one end, but also to see and monitor for trends or any kind of development and report that development to the local folks, whether that's at the state or the real local level or even the facility level, to really make them aware that something's going on. And every step in between. So it's really a circle from reporting to investigation to mitigation. So APIC, my program, I mentioned, we're a secure system, and I believe Jennifer said she sent out a one-pager. Please take a look at that. I mean, do you know that, and I don't mean to discourage anyone, but, do you know that we have about 3,500 users, and we're small intentionally because it's really someone in that role, such as the state EPI or the county infection control officer. It's not open to the public per se. It's not even open to facilities per se. But like I said, I really want folks to understand that this resource network is out there operating for you at the local level. IOSense is another program you may or may not have heard of. They have all kinds of really interesting data coming in, and some examples of that are they are plugged into some commercial resources that feeds in pharmacy data. So then they see, hey, there's a big increase in the ciprofloxacin prescription, for example, from this local area. What's going on? Well, let's look and see if there were, some livestock cases of anthrax. Okay, well that might make sense. Let's look a little further. Or, hey, we don't know why all of a sudden there's 10 times the normal rate of Cipro prescriptions in New York City being filled. So it really goes into the situational awareness, security aspects of things. And BioSense, again, I know I used a dramatic example, but they monitor things like over-the-counter, cold and flu medications, over-the-counter topical steroids, say, hey, what's going on here? Why is everybody getting, anti-itch cream out here? So it really is that's just a very quick example, but they are plugged in not only to commercial data, but of course to healthcare facility data with laboratory feeds for identification of pathogens and identification of susceptibility. PulseNet is also out there, and it's really affiliated with USDA and the FDA. It looks at state and local labs that do food and regulatory testing. So, all of a sudden, hey, you have this new strain of salmonella. And, for example, Salmonella Newport, which was in the news in the last few months. Not that it's a new strain per se, but it really was not previously associated with widespread disease prior to this last cluster. That ended up being a multi-state outbreak. So know that that's there as well, kind of working behind the scenes. Next slide. Partners, and I won't read this to you because I'm out of time, or I'm running out of time. I want to leave some time for questions. But certainly, DGMQ, as I said, is the Division of Global Migration and Quarantine. They have the quarantine stations at the airports and the ports of entry. They do traveler screening and traveler health activities. The National Center for Infectious and Respiratory Diseases, Division of Foodborne and Bacterial Mycotic Diseases, foodborne for short. Certainly federal agencies, we have a very strong relationship with the Department of State for overseas folks, Department of Defense because of their locations and distribution around the world, certainly FDA and FEMA, of course, depending on the event. For two examples, certainly we worked very closely with FEMA after Hurricane Katrina and the aftermath, but we also work with FEMA after tornadoes. And there actually is an association of increases in cases of valley fever, coccidioidomycosis, which makes sense. You get these tornadoes churning up all the soil and throwing it around in the air. Certainly folks are then more likely to breathe in, and if they are predisposed, could develop clinical disease. We work closely with tribal, state, and local health departments, of course, national and international organizations like the International Red Cross and World Health Organization. I listed some really strong partners there, the state and territorial epidemiologists, public health laboratories, etc. Next slide. This one I won't be late, but I really put in there just to kind of pique your interest. I mentioned this at the very beginning. APIC has been helping to foster the secure exchange of information going back to when we were started right after the anthrax attacks in 2001, 2002, certainly SARS. There's a couple of interesting kind of citations there, which I'm happy to send folks information about if they're interested. Novel influenza, I like to plug the fact that we had reports of what had not yet been identified as H1N1 influenza before it was on the media. And we certainly carried the first true identification simultaneously from our labs and Public Health Agency Canada that it actually was a novel influenza agent. Haiti cholera, certainly, and I mentioned PAM a little earlier. Next slide. I already talked about biosims. I'm sorry, this slide's out of order. But again, it highlights, and I already talked about PulseNet. So in the interest of time, I hope that I've covered some of this. I know there's a lot of material. But basically, there's seasonal patterns to illness, especially selected infectious disease. If we're aware and know about kind of the norms, well, then it will pique our interest if there's something outside of the norm or something aberrant. And, that third bullet, I can't overemphasize. Reporting or questioning, even if just a suspicion, is vital. A lot of times that one person that asked that question to say, that got it to the right person to investigate, they've really been instrumental in discovering something going on. Like I said, I tried to highlight the fact that we have a lot of systems and programs in place to monitor and to help to raise awareness of anything that's a suspect situation. Know your contacts, as we talked about, and don't be shy. And really, this may seem trite, but I want to not overemphasize. I don't think it's possible that really it is the astute clinician, and that's all of us, that's out there that may be the person that says, what's going on? So, I recognize that and I thank you, and I really encourage you to keep doing what you do every day. So with that, I'll open it up to questions, and I apologize for running over. I know we started a couple minutes late, but...
Yeah, thank you. Thank you, Jim. This is Jennifer Pelagi. This has been a very interesting presentation, so thank you for going into it. So, Jim, there is a question. There's a couple of questions online here on the chat box. One was, is the CDC finding any correlation between Washington State's pertussis epidemic and a decrease in pertussis vaccinations? Or do they feel it is more related to the vaccine not lasting as long as anticipated?
Good question. I can't answer that yet. I think that is definitely something, or I know that that's actually something being investigated. I mean, nationally, there is some data that shows that pertussis vaccination rates are lower in the last 3 years. I don't know if there's a cause and effect, but I definitely believe that that's going to be one of the, if we can find the data, the folks investigating can find the data conclusively, that's going to be one of the conclusions drawn with the associated recommendation to increase awareness of the need for pertussis vaccine.
Okay, and while we're waiting to see if there's some other questions, I will just wanted to bring to your attention, this is a monthly webinar series. Most of you have been joining us every month. And in August, we have changed the topic, and we are going to be talking about preventing CRE. And we have a wonderful speaker from the CDC, and we also have an epidemiologist from Wisconsin who's going to be talking about their experience in implementing prevention measures. And then in September, an influenza update by a state epidemiologist. And in October, be thinking about Intermountain APIC has a wonderful annual educational conference, and we invite anyone, even outside of Intermountain APIC, to participate. So put a little bit of information on there for you. And then some contact information for Intermountain APIC, myself, my counterparts in Washington and Oregon, and also for Jim. So one of the questions I had come through was around, and it just came to me, but it was just somebody who was asking about mandatory influenza vaccinations, and I wanted to get Jim's input on this, having mandatory influenza vaccinations for hospital employees. How do you feel about that, and with the risk for not vaccinating that a mask must be worn during patient care, that sort of thing?
Yeah, I mean, that's a good question, and I have to say, personally as a nurse, I have to say I have gotten my influenza vaccine every year I've been a nurse except one, and I think it's kind of Murphy's Law that year I actually had clinical influenza, and it was miserable, and I never want to repeat that. But, personally I believe that there needs to be something close to, if not up to, mandatory vaccination. I think that, the handshake of that is that healthcare facilities and companies need to provide it at no cost. But, I personally do believe, and I believe that there's enough data behind it that really does show that by vaccinating the healthcare population, we really do decrease not only the incidence of influenza disease in the patient population, but also in the community. And there's a couple of really good studies that can be found on the CDC web on the influenza pages that look at that based on a really interesting study, and sorry to make this a long answer, in Europe that looked at kind of a referral hospital and a community hospital, and they case controlled and looked at community rates and then case controlled with cities that were similar but didn't have those facilities. And the infection rate in the community was much lower, and the infection rate in the larger kind of community, looking at the referral geography, was lower. So I really do personally and professionally think that there is something to the mandatory expectation. I'm not so familiar with the idea that if you don't get vaccinated, again, if you have a legitimate contraindication, that you wear a mask. I think just from what we know in general about mask wearing, as I mentioned, if you're ill and you're symptomatic and you wear a mask, we know it helps. I think that there's a theoretical basis to support that. I don't know, like I said, as much, but I believe that it's certainly not something that infection control is, pulling out of thin air, or I believe is reckless in recommending.
Thanks, Jim. Let me check with Jeremy one more time to see if we have any callers on the line.
Okay, ladies and gentlemen, to ask a question, please press the number 1 key. There are currently no callers in queue.
All right. Well, we are over time by 12 minutes, and I appreciate a lot of the attendees being able to stay on the line, probably about 3/4 of them. And I appreciate Jim being with us today. I really gave him a big challenge on the topic because I said we're going to step away from straightforward HAIs for a month and just talk about communicable illnesses that still impact healthcare, that we still have to deal with on a day-to-day basis, but to take us on a trip around our public health infrastructure and how that impacts us in our setting, still dealing with the fact that it could be healthcare acquired or communicable in that environment. So I really appreciate how you put this together, Jim, and made it something interesting, a little bit different for us.
Oh, my pleasure. And, again, if there's anyone still on, if there are questions, feel free to email. I mean, I gave my email. I hope I don't expand. But, certainly if there's something I can help direct you to or some information I can connect you to, it would be my pleasure.
Well, with that, I'll go ahead and sign us off for today, and I hope folks will join us next month for the basically looking at the CDC CRE toolkit that was just sort of announced recently. And you all have a good day. Jim, I will talk to you later.
Awesome. Thanks so much, everyone.